Today, the title of my talk is Technology for Improving Health, Wellness, and Successful Aging in Global Communities. Dr. Ernstberger, a couple months ago, invited me to come and talk, and so I gave her a very academic title. If nothing else, my subtitle is The Fountain of Youth. And so in the late 1400s, Ponce de Leon left Europe and went to America to look for the Fountain of Youth. He never found it, landed on Florida, right? And so today you came here, and I'm going to give you the secrets of the Fountain of Youth. So I will do that, and I'll test you at the end. Okay? So this is just the background in terms of what the aging population looks like. We're at an incredible time point where the number of elderly in our worldwide population's accelerating. And so right now in the United States, probably around 47 million who are 65 years and older, or about 14% of the population. Within a couple decades, it's going to grow tremendously to 80 million, right? 20% of our population. Worldwide, this is a growing phenomenon currently. WHO has estimates of around 900 million in terms of the elderly population as of 2015. By 2050, 2 billion. So we're going to double that aging population. So again, I just want to set the size and the scope of this issue that we're going to talk about today. In Europe, by 2050, it's estimated 1 in 4 persons will be 65 years or older. Okay, and so I just want to focus on those statistics there. And as we talk about some of the different technologies today, we're going to look at trying to address why these technologies and how they can help address the issue of successful aging. And we'll specifically talk about some of those terms. Okay. AARP is also in the United States done a study, and they've asked all of their members and cohorts, how many of you would like to age in place? And 90% of the respondents in the survey have expressed a desire to age in place. Age in place means that they want to grow throughout their lifespan and stay in the homes that they grew up in the homes that they had families in the homes that, you know, hopefully they'll have grandchildren share those meals during Christmas and the holidays. And the reason for that, the home is where the heart is, home is where you've grown, home is your support structure, you have neighborhoods and people that are around you. And so that sort of an environment is conducive to your aging and wellness, and you have support structures around you, okay? Now the issue is as we age and as we grow, we have abilities, we acquire disabilities that prevent us from doing so. And there's this tension that happens. And so that's where today I want to pitch to you the opportunity for technology to address some of these issues that could help facilitate this concept of successful aging. Some other issues that arise as people grow and they age, there will be additional requirements for healthcare services. Clinicians, how many doctors, how many College of Medicine students in the room? Nursing students? Okay, excellent. Thank you for your service. We need more of you, right? There's a shortage. The current clinical populations, caregivers, right, we're aging quickly, and so we need more of you out there. So thank you for stepping up and being a leader and taking charge there. It's been estimated that about half of the people who are elderly, 65 years or older, have at least one disability. I have a disability. I can't go anywhere without my glasses. I'm always checking with my kids. I failed my glasses. We acquire these disabilities. In some cases, it's back pain. In some cases, it's chronic illnesses that prevent us from doing the things that we used to be able to do. 1/3 have a severe disability that requires additional care and services, right? And so again, the need for services to support us as we age is important. And then also, if you look at what is available in terms of resources to support the needs that we have as we age, 59% of the elderly depend on Social Security for most of their monthly income. And so again, we're constrained, and if you saw some of the reports, Social Security is going to run out, and that came out there earlier this week, Social Security is going to run out earlier than we expected to. So that becomes an issue and a challenge, okay? The issue for all of you in the room is that as I age, guess who's supporting me in my Social Security as I retire? It's going to be you, right? And so as the population grows in this particular cohort, as there are less workers that are out there to feed into the support services and the system, the burden is carried by you young individuals who are out there working, right? And so how do we do it? How do we use technology more efficiently, more effectively to care for our elderly? That's going to be the topic of today's discussion, okay? And so when I started as a young engineer, a young faculty member, the first thing I was asked to do was to join a think tank over in Sandia National Laboratories out in Mexico. And the issue was what you saw on the screen. The Congress to just declare this as being a national security issue, because this particular issue, as more people age and they require more social services, there's going to be more of a need for our budget to be allocated to care for our individuals who are aging, and it's going to draw from the resources for defense. It's going to draw from some of these other resources. And so we had to brainstorm and figure out, how do we address this particular issue? Right? And so we set out, and this was a mission for us in terms of what to do. The other thing is that as people age, they need caregivers, whether they're formal caregivers like the doctors and nurses that are studying in our programs here, or informal caregivers. And so this statistic is very important as well. And it says basically the typical caregiver is a 46-year-old woman, married, working, spends about 18 hours a week additionally caring for an elderly mother. And the reason for that is proportionally there are more elderly women than men because of a longer lifespan. And then the other issue that's related to this is 2/3 of people who act as caregivers have to pass up on professional promotions, salary raises, training opportunities. And so that glass ceiling that we're having is because of some of these extra burdens that are happening to the young women that are out there, right? And so this is a challenge too. And so this again is another opportunity, and we've been asking and brainstorming and kicking this question around, at least in my lab, for the last 20 years. Question, what is successful aging? So if I can just ask a few of the individuals in the room, when you hear successful aging, what does it take to age successfully? Volunteers? Yes, sir. No pain? Okay. Anything else? Yes, sir. Being physically active, excellent. Anything else? Have you heard that term? Okay. And so, if nothing else, and you're interested in the topics that come out today, Successful Aging is a text written by Drs. Rowe and Kahn. And they summarize about the last half century's worth of work in the area of aging. Everything from health-related issues to psychosocial-related issues and other support structures, done millions, hundreds of thousands of interviews with elderly individuals as they age. And it's summarized in the book. It's a seminal book that came out in the late 1990s. Fantastic book. If you hear nothing else in the next 30 minutes of this talk, I'll summarize it for you in the short answer. There's 3 concepts for successful aging. One is minimizing the risk for disease and disability, or at least minimizing the impact of disease and disability so that no pain. Fantastic, thank you. And then the other one is maintaining physical and cognitive function, so you already identified 2 of them. And then the third one is continued engagement with life. So part of that is you're here in this room, as President Elstner said, you're engaging and learning more about other things around you, society, different topics, right? So the ability and the desire to learn new topics is important. There's some other papers, more recent, that kind of summarize the work and have updated the details on successful aging. You sometimes hear about healthy aging, right? And so there's different terms for this. And so some of these papers, I'd invite you to look more into it if this is a topic that interests you. Okay. As I mentioned, the last 20 years, I've been running the HomeCare and TeleRehabilitation Technology Center. Dr. Ernstberger, I said that a little bit. I've had a little more practice than you have. And so we had 2 missions, right? One is to design, build, and test prototype technologies and potential solutions to facilitate this concept of successful aging. Those 3 things that we saw in the last slide. And then also independent living. And then the second one is to assess how technology can be applied and demonstrated and put out into the field to help underserved populations also achieve successful aging. You've heard about the income gap, you've heard about digital divide. Well, there's also this gap of underserved populations not getting access to some of these technologies. So we didn't want it just to be a technology that serves the affluent. We wanted to help the entire society, right? And so there's several research projects that we've been funded and very fortunate to be funded to support some of the work that you'll see today. One is what we call the Rehabilitation Engineering Research Center on TeleRehabilitation. How do we provide rehabilitation services at a distance? This was a research project, 5-year, $5 million project funded by the Department of Education. Now it's housed under the NIH. The Clinical E-Storefront at Edgewood Terrace is another project that was funded by the Department of Commerce. Broadband Technologies, looking to see how we can apply technology to help serve our populations. And then some of the other projects in terms of wearable sensors I'll show today very appropriate. A lot of you guys, how many people are wearing Apple Watches, Fitbits, trackers, sensors? Okay, so some of the work that you see here will hopefully make it into the next versions of some of those systems. And then I'll talk a little bit about smart homes today as well. So the Clinical E storefront is a project that focuses on that first one, which is minimizing the impact of disease. And this is a project that was funded by a lot of different partners. Community preservation, funded by the Housing HUD. A lot of corporate partners in addition to the Commerce and Department of Education and a lot of different companies as well. And so the project was very simply this. We started in Washington, D.C. It was a dilapidated building in the middle of an urban center. And CPDC worked with HUD to get funding to redevelop these sorts of facilities so that they can put inner city folks, right? And so again, they were going to try and provide these extra services that will help people, across the spectrum, not just for elderly populations, but young African American, underserved, minority, low income populations. And then in the middle of this complex of 5 or 6 buildings, they were going to put a senior building. And let me show you what it looked like after the renovations, right? Same building, okay? And again, the idea was if you change the environment and you provide the services, people will flourish. Does that sound familiar to anybody that's heard President Elsner speak? All right, so 200 units, first broadband facility, wired in every one of the apartment complexes. And now we could see what can we do with the technology to help serve this particular population. We did a survey working with social workers. Dr. Bertera was my partner and collaborator on this. We surveyed every one of those residents in terms of their attitudes towards technology, in terms of what they were doing and how they were caring for themselves, any chronic illnesses they had, mental, right, support structure, and so on and so forth. We found that in this particular population, almost 54% had hypertension, right, had high blood pressure. Another 30% were diabetic. A large population had low back pain, and so a lot of these chronic illnesses. And then we started saying, well, what can we do with technology to address them? And one of the things that we proposed, because we were funded by NIDER in this TeleRehabilitation Center, was we proposed the Clinical E storefront. The idea was working with the hospitals that we already had partnerships with, the National Rehab Hospital, we would actually put at the bottom floor a center in there that residents can come down and virtually connect to the hospital. They didn't have to leave the building, didn't have to get in a car and find transportation, didn't have to worry about any of those things. They can come down, pick up a red line, hotline, and they can talk to a clinician about some of their care needs, right? And so in addition to that, what we did was working with our School of Nursing, we also provided TeleHomeCare services with our School of Nursing at Catholic University. And what that entailed was some virtual visits, as well as daily monitoring of their chronic illnesses. These were people that had chronic illnesses. They weren't acute cases. And so we were trying to help them manage their care and their health even better, right? People that didn't have any habits of monitoring themselves in terms of diabetics, measuring blood pressure. And so we were trying to change behavior. We were trying to move away from a medical model into a preventive model. And that's something that's hard to change, right? Prevention. And so simply how we do it, we didn't have smartphones like we had now. We had this fantastic new building that was wired in every one of the apartment rooms. And then the first thing we realized when we came in is nobody had computers, right? So we had broadband into the homes, and then there were no functioning computers. And then in addition to that, this was an elderly population that we were working with, and the familiarity with computing systems, computers, and mobile devices was very low. Their trust was also very low. And so some of the things that we're learning is there's psychosocial issues, not just the technology, that become barriers to adoption of these technologies, all right? And so again, we were trying to implement these telehome care visits. And so when we came in, it was a biomedical engineer, myself, and some of my students walking in with our nursing colleagues and faculty. As we were deploying these technologies, we would have a suitcase that physically connected to a modem, to a hardwired phone line, a copper line in the home, okay? Now, 20 years later, post-COVID, we have a lot of these technologies we're deploying now. In the early days, we actually had to deal with a physical phone line and a modem. That was the only thing that was reliable. That was the only thing that was working in those units as we were coming in. In addition to that, that modem allowed us to transfer information, monitoring data, And so that included blood pressure data, it included weight scale data, and it included diabetic data as well. So blood glucose that would be monitored, and we were trying to change behavior and to get them to implement these practices. And so the schematic of how it worked, they would make those measurements, we would ask them to do it every day, and then that would automatically get ported up, sent to a remote server where we were logging the data, we can track the data, and then through those, our nurses could make these televisits and intervene, right? Prompt them to make these behavioral changes, prompt them to eat better, and then telecoach them along the way in their management of the diseases. This is what some of the data look like. We can graphic longitudinally, we can look at average data, we can look at variability in data, which is important when you're looking at diabetics, how much they fluctuate. And so we can gather a lot of data. Now we can do that pretty easily, right? And so again, we can flag it, and then those could be topics that prompts the next telehealth visit with a nurse, a home care nurse, or a remote clinician. And so some of the things that we found, there was really a high compliance with monitoring. In our period of study, we were looking at 90 days to see whether or not people would comply to these new behaviors we were trying to teach them. It was fantastic. It was 1 missed day a month on average, right? Going from 0 to 1 missed day a month, right? And again, if you talk to some of the doctors in the room, the faculty members, compliance is one of the hardest things that you can do, in people who are needing to care for themselves. And so we were teaching them new behaviors. We intentionally didn't bring the equipment out of the home until after the study ended. So it was a 90-day period. We left it in for another 2 months to see what would happen. They weren't being prompted anymore. They weren't being called. And what we found was they were still monitoring themselves 2 months after the study until we moved the equipment out, right? So we knew that our protocols, our intervention, teaching them how to take care of themselves, they would be compliant with it and stay with it even after we were done. So that was a success for us, right? Self-efficacy, we did a survey afterwards. How did you feel about and were you able to manage yourself? We increased their self-efficacy and their confidence in terms of caring for themselves. And then lastly, this concept of telehealth and whether or not they would accept telehealth, and this was in the early days of telehealth. We saw a positive reception of that, significant values in terms of the responses in all of these categories. So that emboldened us. And so some of the things that we learned, again, I'm just leaving these comments for our nursing folks and the College of Medicine as well as lessons learned that maybe could be incorporated if it hasn't been done already, right? We need to train our providers and caregivers in the use of telehealth technology. How do you talk to people? How do you approach that? How do you debug? How do you get them comfortable with the equipment? Because if the providers are comfortable, when the issue arises on the other side and the patients or the consumers are not comfortable with the technology, you can help walk them through it. First thing we saw in some of our earlier studies with our telenurses is when that screen goes dead or system crashes, they said, these systems don't work as reliably. And then that conveyed to the end users and the patients, okay, well, this might not be something I want to use all the time. So usability is an important issue. So, we need to embed that into our curricula in the nursing school and the College of Medicine before we roll it out and ask our patients to use these systems. Rapport is very important as well. This isn't just the technology, it's not a transaction. When we deployed those technologies and into the home, developing that rapport, that conversation, that visit is important. It's what we call the bedside manner, right? And so developing that relationship while you're physically in the home so that when you actually are making the virtual visits, that will stick, right? And so that was another lesson that we found was very important, developing that relationship early, because these virtual visits, otherwise they become transactions. Just like what all of you students have been through in the last year, we go on these Zoom calls, and then you click off and you're transitioning to the next visit, right? And so something's got to stick, and that rapport and that relationship is very important. And what we found was these were much more useful. Our telehealth nurses can make 15-minute calls and visit more often, as opposed to getting into a car, driving for an hour to get to the home, or the patients getting into a car, driving into a hospital somewhere, sitting in a waiting room for an hour before they're seen. Much more efficient and cost-effective all around. And so what we did was, because of the success, we were asked to extend this effort up in Connecticut and the Eastern Seaboard. Insurance companies were very interested in this, because again, this is more efficient and more cost-effective. So that was one of the things that we were trying to do in terms of minimizing chronic illness. We all acquire chronic illnesses, we haven't. Something else we were interested in as we were making these visits, a lot of our customers and our nurses and the clinicians we were working with, falls was a big issue that they had, right? And so we thought, well, how can we use technology to address falls? Falls results in hip damage, it results in head concussions, and so a lot of bad things happen. And as we were looking at the data, over a third of the elderly over 75 fall at least once per year. And 50% of those falls, head injuries, and they lead to severe disabilities, and a lot of times within a year, death as well, right, because of those injuries. And some of the things that we heard as we were hearing falls are because of medications, because of stroke events and other events, and these are people that are living by themselves. And so a lot of times what we heard with some of these individuals we were interviewing was it would be hours before they would get help. Think about that. You fall, you break a hip, and nobody comes, for hours, right? And so this was an issue that we thought that we can do something about. And then the other part about this is falls happen, but there are near falls that happen as well that nobody ever reports. Injury didn't happen, but again, that could be an early indicator of some other things that are in the works. And so we thought that we can use technology to help address some of those. We put accelerometers into boxes, we put boxes with microprocessors on them, and we put communication systems into them. And then what we did was we sent them into the home. First, we tried them on college students like yourselves, and so you'll see some of those videos, but we were looking at the biomechanics of motion and movement so we can try to effectively detect falls that happen and try to minimize false alarms that came out. And so this first one is a video. Again, please don't record this. These are my subjects, and so this is an example of one of the activities. This is a subject wearing our sensors. And while they're doing all of these different activities, sitting down, standing up, walking up, and then falling, and we would ask them to do these falls, forward, backward, side, all of the different directions. And we were gathering biomechanical data as they were performing these events, right? And so we collect them all over a bunch of subjects. And then in addition to that, what we did was we asked them to wear it for a month. Take it home, wear it, we're collecting data on you. And so they're walking around up and downstairs, going to class, and so we started with students, and we're collecting all of this data, as you can see. And what we're trying to do is, what are the signals that will tell us what the people are doing? First, we started with falls, and I'll show you what that looks like. Just get to the next slide here. All right, and so this is what the signals look like. As signals do, if you stand, you walk, we can collect some of this. This is what your Fitbit and your Apple Watches are doing, right? And so what we can do is you can see with the fall data there right above me, I think I have a pointer, there's a big spike, and that spike happens when you hit the ground, right? And so that's the impact that happens. And so we were trying to look for these signals, and you would think it would be easy to do. Well, it changes depending on what you're wearing. It changes depending on what surfaces you're landing on, if you're landing on a carpeted surface versus a hard surface. And so there's a lot of variability in terms of what that signal looks like. And so we were developing algorithms to look and see if we can detect that. Well, if you look at some of the other signals, like when you're running and bouncing around, that also causes large impacts as well. And so we didn't want to have those sorts of activities be confused with a call, because if we're dialing 911 for emergency services, that becomes a problem, and it's the boy who cried wolf, right? And so that becomes expensive after a while. And so a lot of our efforts have been looking at trying to identify what that fall signal looks like. And so what we did was, rather than just looking at that impact, we're going to add a second sensor. We're going to try and figure out when you fall, your body rotates. And so in addition to the accelerometers that we use what's called a gyroscope, and that measures your body's rotation as you fall. And at some point you hit critical velocity, and that means you can't recover. And that's the second signal that we were looking at. Not just the impact of the fall, but also your body's rotation. So two things that will confirm that particular event. And so what we did was we tried to identify what those thresholds would be for each of those signals. And what you can see from this is the sensitivity of our algorithm with the additional sensor. Right? The sensitivity, which is the correct detection of that fall event, was pretty high, 96%. But the specificity, which is the false alarms, right? That specificity increased considerably compared to just using the accelerometer alone. Most of the algorithms only use the accelerometer as a simple sensor to add to systems. But we thought that with the second sensor, we can do this even better. And so that was very effective for us. And then this is what it looks like, and you can see where the events happen as we're walking, sitting down, standing up. And then that fall impact at some point should be synchronized, and we can detect that pretty well, right? 96% sensitivity and specificity. Most of the literature was showing around 90%, 95% sensitivity, but the specificity was in the 70s and 80%. Right? And so we worked, a lot of students worked very hard on this in terms of optimizing that algorithm. Some of the things that we can use is we can use this to look at falls, right? So detect when somebody falls in a bathroom, at a home, in a hospital. For some of you doctors and nurses, we still have pull cords in there. Why do we need pull cords? Let's have a fall sensor that will alarm the central nerve station, right? That they're wearing all the time. Then, as engineers, we kind of do wonky stuff. Well, we said, what if we can connect this system into a system that deploys airbags, right? So when you fall, if you can launch it fast enough, we can reduce the impact and the injury. And so we had some students try that as well, right? And then we said, well, what if we can go beyond fall detection? What if we can help identify different activities? Well, that would be useful for social workers if we can understand what people were doing. That would be interesting for occupational therapists. That would be interesting for a lot of different cohorts. And so that was our next task. We took that same set of sensors that you have there with the accelerometers. We're looking at the total magnitude. We're looking at the X and the Y and the Z directions. Then we're looking at the gyroscope, and we're looking at each of those directions. Then we use machine learning algorithms, looking at a bunch of different features to see if not only can we find falls, but we want to know when you're sitting down. We want to know when you're sleeping and lying down. We want to know when you're walking up and down stairs. And again, you're wearing this 24/7. And the way that we can collect these signals and using this, we can break it down to a bunch of different activities that will tell us and might give us early indications of whether or not people were depressed, whether or not their changes in behavior were related to their illness, and giving us really granular data in terms of what people were doing. And so that was our next effort in terms of how we go about doing this, and we developed algorithms around that. Let me go ahead and start this. And again, the dumb signals are up at the top. As clinicians, you don't want to see the raw bits and data that go around. But what you want to do is how much time are people actually walking around? How much time are people lying around? Because maybe that's related to a heart attack that's forming in the next few months or so. What do those behavioral activities look like? And so this, for us, is a really difficult thing to do because all we're seeing is you moving around. And now we're making estimates of whether or not you're cooking in the kitchen, whether or not you're interacting with somebody else. And so it's just using these sensors as we walk around. It's very difficult, and we have to have these sensors happen 24/7. They're wearing them, and so practical implementation issues like battery life and some of these other wearability, usability issues come into play. Okay. And so that's where we're headed. And then we said, well, okay, if we understood when falls happen and we understood what people are doing, could we even do more? Could we assess people with these for risks for falls? And so CDC has certain guidelines. They're called the STEADY guidelines in terms of certain things that you do in the clinic that we can assess your likelihood for falls. And so that was our next step. We took the same set of sensors and we applied them to the timed up and go test. How fast can people get up from a chair, walk 10 feet and come back? There's an early indication that CDC says that if it takes you longer than 12 seconds, that's probably a sign of a likelihood for falls, right? Well, can we do that with our sensor? Well, our sensors can detect walking. Our sensors can detect when people are standing up and sitting down. So we said, well, why not, right? And so we did that. We implemented those. These are the signals that we said that we saw. And so we can certainly measure how long it took for you to get 10 feet and back. But then we said, well, if we looked at that data with a little bit more granularity, we can get other things. How long did it take for you to get up and down out of a chair? If you're weak and your muscles are weak, it'll take you longer than somebody who's able-bodied and strong, right? And so that might give you an early indication. We can look at how many steps you took. We can look at the average speed that you had, not just over that time duration that's limited in the tug, but we have all of these other measures that give us granularity about whether or not you're favoring your left foot versus your right foot. We can look at the cadence, okay? And so using some of these measures, it gives us a richer set of data that we can use. Another part of the steady test is the 30-second chair stand, right? How many times can you get up and down out of a chair in 30 seconds? And we can use our sensors to do that as well because we can classify some of those activities. And so here's the guidelines from the steady test CDC. You'll find these on CDC's website. Nothing magical, but the only thing is we're applying sensors in order to look at this, right? The last part is the 4-stage balance test, so the clinicians will know. So different postures and how you stand, right? So side by side, one foot slightly in front of the other, definitely in front of the other, and then on one foot. And you're supposed to stand in each of these postures for 10 seconds. They get increasingly more difficult. And then from that, you can detect whether or not you have a risk for fall. The hardest one is stage 4, which is on one foot. When you leave the room, when you're going back to your dorm or whatnot, stand on 1 foot for 10 seconds. It's a lot harder than you think. Right, and so here's our sensors. For the most part, you can see, at least for that stage 4 test, 1 foot, that was the most difficult. And you can see it becomes more erratic as the duration goes by, right? And so we can detect that and we can look at your balance issues. Not just to look and see whether or not you'll tip over, but we can actually have a quantitative measure for some of this. And then in addition to that, we say, well, we already have a measure of your X, Y, and Z gravitational positioning with the accelerometer. And so then what we can do is we can figure out where your center of gravity is. And we can actually measure your balance by looking at how much sway that you have. And we can integrate that over time and figure out how much distance and wobble you have when you're standing on 1 foot or in these different postures. And we can give a quantitative measure to a clinician and say, this person is likely to fall and they're a cutoff. And so we can provide objective data for that. Our intent, as we started the day, everything goes into the home. So this is something that doesn't just happen when a person decides to come into the clinic, but now you're wearing these sensors and we can collect this data from the home, right? When you're walking to go into the kitchen, we can collect the timed up and go data. So it gives us much more granularity of what's happening in the home environment as opposed to the episodic data that comes when you're just coming into the clinic. We've been playing around also. There are 3 aspects, right? So the first aspect is health and avoiding disability. The second one is maintaining physical and cognitive function. And so certainly we've done some things there. We're instrumenting homes. We're looking at toolkits. As a young engineer, I read Bill Gates' book, The Road Ahead. And he talks about the millions of dollars he spent in to update his home out in Washington. And it was expensive to do. But there are fantastic things that could personalize interactions with each individual that is walking around in that space. And so there's been a lot of work in terms of how can we create smart homes that interact with us. If you think about what a home is, static walls, right? Maybe some home automation if you have an Alexa or you have a Google device, but for the most part, pretty static all around. Okay, and so a lot of effort has been going on in the last couple decades in terms of how do we make those homes smarter that respond to us, that can do assessments, that can measure cognitive load and remind us about medications if we need them and make measurements. And so we were looking at how can our technology be able to do that, but again, how can we make it affordable for a broad range of the population? People who can afford it, low income, minority, all of those issues that you saw in the first few slides. Right? And so we call that our consumer toolkit. And what we did in that regard is we went and found some cheap, inexpensive sensors, motion sensors that are IR sensors that you see every day. And again, as you move into a room, we have rooms that, we'll have IR sensors that turn the lights on and off. Well, we were using those to detect people coming in and out of the homes. And so we were developing hardware and software. We would put these sensors in every room. And again, we would plug it in, that would turn on lights as you walk in, and we would plug these in. You can buy a whole suite of these things for $150, right? And so by doing that, we can connect it and we can collect data in terms of who's walking in. And then from an environmental perspective, not something that you wear, because sometimes people take things off and you don't, collect data from them. So we were actually trying to identify where people were and making estimates of how much activity they were having in that particular space. And if we can do this over long periods of time, what we were looking for is, does behavior change result from chronic illnesses or early events before they happen? And we were trying to be predictive in that, right? And so again, project was to develop low-cost smart home toolkits that we can deploy in the environment quickly by plugging it into outlets, and it would collect data from that home, how people were interacting with that environment. And if you need to, you can also add that layer of home automation to it, so you can help support individuals as they are living in that space and aging in place. And so we're developing pattern recognition algorithms so that we can predict when events were going to happen. So a lot of different opportunities there in terms of where you can deploy them: assisted living facilities, continuous care and retirement communities, individual homes. And again, we can use this to track and predict disease and coordinate that with wearable sensors and other devices that we had talked about. All right, and again, supporting that aging in place. And then we also looked at it and said, well, what can we do in the area of cognitive assessment? And so lately, we've been very interested in terms of wearable sensors so that we can measure cognitive function and cognitive load. And so again, these, what you'll see when you're in the clinic, is a bed of these EEG sensors, and that's the level of granularity it might need. And so now, folks that are using some gaming stuff, right? And so there are headsets that will allow you to collect EEG data. And so we've been using some of those to see whether or not we can quantify and look at cognitive function in the home environment. And so some of the projects that we've had, we've taken the data, which is not so useful for the clinicians, and we've actually identified where active areas are functioning as you're performing different exercises. And so you can do this to assess memory. You can use it to assess response times. I think the key part of this industry is probably going to use this for biometrics and how you access computers and banking systems and things like that. And so other applications that not directly related to successful aging, but again, I think that sometimes those drivers will drive down the cost, and then you can deploy it to other populations that need it. Okay. And again, so if nothing else that you don't remember out of this, there's just 3 parts to successful aging. One is avoiding and minimizing disease and disability. Second is maintaining physical and cognitive function. And then the last part is engaging and being involved, right? Your mental attitude and how you interact with your community and the others around you goes a long way in terms of your ability to age, right? And so stay engaged, volunteer, join communities, play sports, learn. It'll change your whole perspective on things, okay? And then for the clinicians in the room, just remember as you're deploying technology, even as an engineer, technology is not the solution. Technology is just a tool, that it's you and your individual and your application that are driving those changes that are happening, okay? And so even as an engineer, we always look at the technology and supporting what you're doing, giving more data, more granularity to what you're seeing and observing. All right, and so we are firm believers that technology provides greater access and reach, and it drives down costs, and it's equal for everybody, and not just for one cohort versus another. Okay. And I'll just end with this slide, and I think Dr. Ernstberger has another one. A lot of different collaborators when we do these sorts of research, social workers, engineers, nurses, doctors, and so as you're looking through these sorts of teams and these sorts of efforts behind it, it's a whole bunch of people, talented people that I've been very fortunate in terms of working with, and that are driving change. And sometimes that change, as I mentioned, is not technological. The barriers a lot of times are psychosocial, political, and policy change. And so if you have an opportunity to drive policy change and societal change, that's where it happens. The technology is just a tool to solve some of these issues. All right, thank you. So I think there's a huge role in it. One of the key aspects, yeah, so the question was, what's the role of spirituality? One of the, on that page, and I can bring it back, but there is a nice paper that came out about that added dimension of spirituality. And I think it comes back to your perception of how much you can control the world, and your acceptance of what comes at you, and grittiness, and resiliency, right? And so I think spirituality is a big part of that. When you're spiritual, you have faith that things are going to work out, and you have faith in a higher being, and so that does change what's, I think social workers will call it self-efficacy, I think is the term, right? How you perceive yourself and how you perceive the world, it changes, your ability to kind of manage your own health and wellness and successful aging. Is there a question in the back? I can a little bit. I'll repeat the question. So the question, just to repeat it for the folks who haven't heard, is how practical is it for these sorts of technologies to make its way to lower income, diverse populations that might not have the resources for it? I think it's practical, and that's where, when we were deploying the clinical e-storefront, insurance companies, folks who have a motivation for seeing these technologies work. I think it requires partnerships. It requires understanding who benefits for having these technologies. It's not just the individuals and consumers, but if it saves money for the insurance companies, right? The folks that we partnered with, Verizon, what does Verizon do? They sell broadband, right? And so if these sorts of partnerships happen, then you can make it out into different communities and you get access. I think we're gonna, in the next 3 to 4 years, 5 years, we'll see a leapfrog in terms of the capabilities of telecommunications with 5G coming out. We can send so much more data, so much faster, and at a cheaper rate. It'll leapfrog. Our issue, as I told you before, not every apartment when we first started out had the broadband. Well, the problem with that is because we couldn't get fiber into those communities and those homes. All that goes away with 5G. We don't need to dig lines and lay down fiber and all of that stuff. We can actually transmit it wirelessly, and that opens up a bunch of doors. Yeah, so I think that that's a fantastic question, and that's what I mean by the barriers not being technological. A lot of times it's social and how we deploy and roll things out, right? And so in our particular population, the folks that we were working with, everybody spoke English. But if we went to a different community with different, requiring different languages, we would have our training materials in those different languages. We would have nurses probably that spoke that language as well. Again, it's about that rapport, and people accept you a little bit more if they get a feeling that you're like them. And so, again, I think that you brought up a great point, and we need to develop materials and training tools and equipment and be sensitive to the cultures. That's a great question. Yes, all the way in the back. So one of the big barriers to telehealth and telemedicine for a long time was the willingness to reimburse, right? I'm sorry, the question is, what's the role of public health and other cohorts to help push this along, not just the engineering and the nursing, right? And so that's been the biggest challenge for a long time is the barriers to adoption of telehealth was reimbursement, right? Policy change, the questions that you're specifically talking about. So I think there's a big role in terms of changing reimbursement policy, in terms of licensing. So telehealth, one of the big barriers, what you have here in Indiana, when you crossed over to get to Iowa or Illinois, you might not be licensed. And so those sorts of policy changes, I think, from the top down, could really push this forward. And I think we saw that in the last 18 months with COVID. Out of necessity, people couldn't come into the hospitals, couldn't come into the clinics. And so we had to relax some of those. And so now that we have a taste that this works and that people won't abuse it, I think that we'll see a lot speedier change. It took us 20 years to get to this sort of area, and then within 12 months, COVID changed everything. And I'm really excited about where this technology is going.
So I want to honor everybody's time tonight, and including Dr. Tran. So I'm going to take one last question. I'm going to privilege of students. Do I have any student questions? The last student has a question. First arm up. There you go.
Are you going to continue your research here at America?
That's a great question. I'm going to torture my students, and we'll push that through, and I'm looking for collaborators as well as we move forward. I think there's still a huge need and large opportunity for technology to help. So, thank you very much for your time. I appreciate it.